Combined laparoscopic perineal hernia and abdominal laparostomal hernia repair. We present the clinical case of a 22-year-old male patient with a history of extra-elevator abdominal perineal amputation for rectal cancer. He presented with complaints of discomfort in the perineal and laparostomal regions. On physical examination, both perineal and laparostomal penetrations are observed. An abdominal and pelvic CT scan was performed, which confirmed the diagnosis. A multidisciplinary team meeting was held to choose the best surgical approach for this case, perineal versus abdominal. Given the presence of a parastomal penetration, an abdominal laparoscopic approach was chosen for the repair of both defects. Exploratory laparoscopy enterolysis was performed. Small bowel serosal injury occurred during the procedure and was repaired with interrupted vicryl sutures. Firm adhesions of the small bowel to the pelvic region were noted. Due to the complexity and risk of inadvertent injury, a perineal approach was added to safely complete the dissection. A 5 cm perineal incision was made. The abdominal cavity was entered, confirming the presence of adhesions. These were carefully released. The small bowel was successfully freed from the pelvis, confirmed through digital exploration. Layered closure was then performed. The dimensions of the defect were measured using surgical lining in order to tailor the mesh accordingly. A dual mesh was introduced into the pelvic cavity. It was fixated to the sacral promontory using tackers. A running barb suture was used to close the peritoneum. The end of the running suture was reinforced with clips. Excess mesh was trimmed and a defect in the mesh was repaired using interrupted suture with Vicryl. A peristomal eventration was identified and the defect was repaired with 3/0 Vicryl sutures. A dual mesh was introduced and fixated with tackers. The mesh was trimmed and both meshes were confirmed to be securely fixated. The patient remained in the general ward during the postoperative period. Oral intake was initiated on postoperative day 1 following the return of the colostomy function. On postoperative day 2, routine laboratory tests were performed, revealing no abnormalities. The patient was discharged on postoperative day 3 without complications. Thank you.